Welcome. In the third session of Neuro-ophthalmology, we will be discussing the first part of examination and diagnostics. And in this first part, we will be discussing clinical examination and neuroimaging. So when the patient presents to us, we should be taking a careful history about the symptomatology. A unilateral involvement suggests prechiasmal lesion, while a bilateral involvement suggests a chiasmal or a retrochiasmal lesion or a bilateral prechiasmal lesion. The presentation or the symptomatology may be of acute onset, and after the onset it may progress further or may remain stable. So this kind of a presentation is suggestive of either ischemia or hemorrhage. In a subacute presentation, over days to weeks, we think about inflammation or demyelination, the most important type of inflammation in neuro-ophthalmology. And we also consider infections. In a chronic presentation, the onset is insidious over months to years, and the symptomatology gradually deteriorates very slowly. And in this situation, we think about compressive lesions, that is space occupying lesions pressing on the nerve or the remainder of the visual pathway, nutritional and toxic etiologies such as vitamin deficiencies, drug toxicities, etc. Now we should remember that among the toxic optic neuropathies, methanol is an exception because methanol toxicity presents acutely and suddenly. Among the associated symptoms, probably the most important is periorbital pain on eye movement in optic neuritis. So a patient complaining of orbital pain or pain surrounding the eye when he or she is moving the eye suggests optic neuritis. In the examination section, the first thing to record is visual acuity. If there is an improvement of distance visual acuity or best corrected visual acuity with a pinhole, it suggests a refractive error. The near BCVA level should match the distance BCVA level, that is, they should be affected to a similar extent. Eccentric fixation during assessment may suggest a central scotoma, and tendency to read letters on one side of the chart, either the right or the left, with either eye may suggest a hemianopia. An improvement in the distance BCVA with single optotypes suggest amblyopia. Single optotypes are those in which a single letter is projected on the chart at a time of various sizes. Color vision should be tested one eye at a time because the optic nerve involvement may be unilateral. We have Ishihara plates which tests for red-green deficiency, and we have Hardy-Rand-Rittler plates which can also assess for the blue-yellow axis in addition to the red-green axis. Both optic neuropathies and maculopathies affect the blue-yellow axis and not the red-green axis, which is mainly affected in congenital situations. Optic neuropathies, particularly demyelinating and compressive optic neuropathies, affect color vision more severely than visual acuity. Maculopathies may also affect color vision, but it affects color vision to the same extent as visual acuity, except probably cone dystrophy, which may affect color vision more severely than visual acuity. In the previous video, we have seen that the pupillary light reflex is a simultaneous and equal constriction of both the pupils when light is shown in one of the eyes. So relative afferent pupillary defect, a very important sign in neuro-ophthalmology, occurs when the afferent component of the pupillary reflex pathway from the retina up to the pretectal nuclei is affected on only one side or is unequally affected on both sides. When light is shown on the unaffected eye, both pupils constrict. Here is a diagram showing left RAPD. So the afferent pathway is defective on the left side. So when the light is shown on the unaffected eye, both the pupils constrict, and when light is shown on unaffected eye, neither pupil constricts. So what do we get effectively? When the projected light is shifted from the unaffected eye to the affected eye, the affected pupil, which we are now seeing, appears to dilate, from being constricted to becoming dilated, or they constrict slowly and to a smaller extent if some amount of the reflex is intact. This appears to happen even though both the pupils are dilating at the same time when we are projecting the light on the affected eye. Both the pupils are dilating. In other words, when light is shown in one eye, the direct response in the same pupil and the consensual response in the opposite pupil are the same. So what are the conditions causing RAPD? Optic nerve involvement is the typical condition causing RAPD. Chiasmal lesions involving the optic nerves approaching the chiasm unequally can also cause RAPD. Optic tract lesions cause mild contralateral RAPD. This is because the crossing fibers are more in number than the fibers which remain uncrossed in the optic chiasm. So there is an unequal contribution from nasal and temporal retina in each eye. If the pupillomotor fibers are affected after leaving the optic tract, that is in the brachium of the superior colliculus, a contralateral RAPD occurs without affecting the visual acuity or visual field, which runs to the lateral geniculate nucleus along the optic tract and does not take the pupillary light reflex pathway along the brachium of the superior colliculus to the pretectal nucleus. Extensive retinal lesions like retinal detachment and ischemic CRVO also cause RAPD. So this is important. The retinal lesion has to be extensive. A small retinal ERM membrane or a macular hole will not cause an RAPD. Unilateral cataract may cause a mild contralateral RAPD. So this is something anomalous. How can an unilateral cataract cause a mild contralateral RAPD? That is by scattering of light in the cataractous eye, which stimulates a larger number of photoreceptor cells in the cataractous eye. A dense amblyopia may also cause RAPD. RAPD may vary from immediate and sustained dilatation of the pupil of the affected eye to sluggish constriction of that pupil. The RAPD can be graded by performing the test with neutral density filters of gradually increasing intensities, which are placed over the or in front of the unaffected normal eye, beginning with the lightest filter, till both the pupils react equally when tested. Bilateral optic neuropathies and retinopathies, when equally severe in either side, will cause sluggishly reacting pupils on both the sides without RAPD. RAPD does not lead to anisocoria. This is a very important statement. We will be learning about anisocoria in a subsequent presentation, and anisocoria refers to the unequal size of the pupil on either eye. This does not happen due to afferent pathway defect. That is because the afferent pathway supplies the pupil on the both sides. If pupil is dilated in an eye with decreased vision, as may happen in trauma, a trauma can cause injury to the pupil and the optic nerve separately in the injured eye. The RAPD can be demonstrated in the affected eye by checking the pupil of the unaffected eye for its consensual and direct responses. The direct response to light shown in the normal eye is normal, while the indirect consensual response of the normal eye when light is shown in the affected eye is poor. So the pupil in the traumatic eye remains dilated whether we shine light on the normal eye or in the affected eye. But the pupil of the normal eye tells us whether the afferent pathway in the traumatized side is affected or not by dilating when light is shown in the injured eye. Optic nerve examination reveals whether the optic nerve head is atrophic or edematous. Optic nerve head atrophy results from axonal damage of retinal ganglion cells at any level from the retina to the lateral geniculate nucleus. It takes at least several weeks to appear after the damage. The further away the damage occurs from the optic nerve head, the more the time is required for the optic nerve head to appear pale. Severe atrophy results in chalky white pallor of the optic nerve head, whereas mild atrophy prior to actual occurrence of pallor can be discerned from loss of capillary network over the optic nerve head or loss of the peripheral retinal nerve fiber layer. However, if the loss of the peripheral retinal nerve fiber layer is diffuse, it can be difficult to detect clinically. Now, in a patient who is pseudophakic in one eye, the optic nerve head may appear pale in the pseudophakic eye, and that should be distinguished from actual pallor. Optic nerve head edema results from compression, inflammation or ischemia of the optic nerve, or can be due to a raised ICT compressing on the nerve. These cause arrest of exoplasmic transport, and accumulation of the exoplasmic material results in edema. So there are 5 mechanical signs and 5 vascular signs traditionally described in optic nerve head edema. The 5 mechanical signs are elevation of the ONH. So the ONH actually appears to be projecting into the vitreous cavity, towards the vitreous cavity. There is loss of cupping. There is blurring of the disc margins. The disc margins is not well delineated, and there is opacification of the PRNFL. The opacification of the PRNFL has feathered edges and obscured the superficially located small retinal blood vessels. There can also be retinal and choroidal folds. The 5 vascular signs are venous congestion of the arcuate and peripapillary vessels, pallor, which happens in GCA or arteritic AION, or hyperemia with dilatation of the capillary net. In most other conditions, usually at least in the initial stages. We will also find papillary and peripapillary hemorrhages, hard exudates and cotton wool spots. Now we must be able to differentiate a true ONH edema from pseudoedema. Pseudoedema is a edematous appearance of the optic nerve head, which is typically seen in optic nerve head drusen, but the disc is actually not edematous. So the true ONH edema shows 3 features which are not found in pseudoedema. Number 1, hyperemia of the optic disc. Number 2, opacification of the PRNFL with obscuration of the blood vessels at the ONH margin and peripapillary retina, and vascular changes, that is vascular dilatation, hemorrhages and exudates. This is a very important differentiation. Coming to visual field examination, field defects arising from post-chiasmal lesion respect vertical meridian. This is because of the decussation of the nasal retinal fibers in the optic chiasm, whereas optic nerve head lesions such as glaucoma and AION have field defects respecting the horizontal meridian. Here we must remember that occipital lobe lesions may have field defects respecting both the vertical and the horizontal meridian. Confrontation testing is a gross assessment of the visual field of the patient without using any machines, and we can do it in the clinic. It has a low sensitivity, but if we find abnormality, it is highly specific, and it is useful for patients who are unable to undergo a formal automated or kinetic perimetry. The examiner sits 1 meter from the patient, and the patient covers the eye not being tested. There are various methods of confrontation testing. We have the face recognition. So while focusing on the examiner's nose, the patient tries to assess whether he or she can see all portions of the examiner's face. Then we have finger counting. counting fingers shown in each quadrant, the suprarenasal, the inferonasal, the supratemporal and the inferotemporal separately. Then there is the kinetic red target test, which is said to be the most reliable, in which a red target is brought from the periphery to the center, bisecting each quadrant at a time, and the patient notes where the target is first perceived to be red in color in each of the quadrants. Then we have the finger or red target comparison, in which fingers or red targets are shown simultaneously in two adjacent quadrants across the vertical meridian, and the patient is asked to note if they can appreciate any difference in either sharpness of the target or the color of the target. Extinction or visual neglect refers to inability to see a target in an affected hemifield when presented simultaneously with another target in the adjacent normal quadrant, but not when presented alone. It is a characteristic of parietal lobe lesion and is called hemifield neglect, which we will be discussing in a subsequent presentation. Amsler's grade assesses the central 10 degrees of visual field. The patient must hold the Amsler's grid at a distance of 33 centimeters from himself or herself while wearing the near correction. The patient has to focus at the central point, and the patient tries to assess if there are any specific areas which either may be distorted, so the area may be distorted indicating maculopathy, or absent. So an area may have distortion of the straight lines, or the patient may perceive no lines in that area, and the patient must record that area by drawing the region on the Amsler's grid for future comparison. Coming to neuroimaging, magnetic resonance imaging is the most useful modality in the majority of neuro-ophthalmic patients. The principle lies in protons in the water in various tissues, and these protons align themselves in a strong magnetic field. Then a radio frequency pulse or a magnetic gradient is focused on the volume of tissue to be imaged, which reorients the protons. After the pulse is extinguishes, the protons return or relax to their original position in the magnetic field. This relaxation emits radio wave signals which are captured and used in producing the image. Two aspects of relaxation are evaluated. One is the relaxation parallel to the magnetic field, or the longitudinal relaxation, also called the spin echo or T1 relaxation, which occurs earlier, and the other relaxation is transverse to the magnetic field, called the spin-spin relaxation or the T2 relaxation, which occurs later. TE is the time from the RF pulse to when the signal is captured, and TR is the frequency of repetition of the RF pulses. T1 weighted imaging uses shorter time to echo and shorter time to repetition, while T2 uses longer time to echo and longer time to repetition, and we can have various combinations of either TE and TR. MRI allows detailed study of brain and orbits. MRI of both brain and orbits is often required in the neuro-ophthalmic situation. MRI gives a good resolution at orbital apex and the posterior fossa of the brain. Standard sequences are relatively insensitive to acute hemorrhage, but show chronic hemorrhage well. Bone is also not imaged well, so these are two features which are not shown very well by standard sequences of MRI: acute hemorrhage and bone. MRI does not use ionizing radiation, but since it uses a strong magnetic field, it cannot be used in patients with metallic foreign bodies and implants. However, whether the patient has any metallic foreign body or implant can be screened with an X-ray or CT before actually doing the MRI. Titanium mesh and gold weights do not move in magnetic field, and so they are not contraindications to a magnetic resonance imaging. MRI is costlier with longer image acquisition times, and it is difficult in claustrophobic and very obese patients. Gadolinium, which is chelated with DTPA, based contrast agents improve study results in MRI. These contrast agents traverse altered blood-retinal barrier to accumulate in pathologic areas. They are usually used in T1 sequences along with fat suppression for orbit. We'll come to fat suppression a little later. It is very helpful in optic neuritis and meningioma. So gadolinium enhanced fat suppression sequences are most useful to image the orbit for detecting optic neuritis and meningioma. Contrast agents of MRI are relatively contraindicated in compromised renal status. In such a situation, they may cause a nephrogenic systemic fibrosis, which may actually be fatal, but happens very infrequently. The gadolinium-based contrast agents have less chance of allergic reaction than iodine-based contrast agents for CT scan. So there are several types of sequences which can be employed for better tissue differentiation. In a sequence, each tissue responds differently due to the amount and state of binding of water in that tissue. We have the T1 sequence in which the fat appears hyperintense, and CSF and vitreous appears with very low intensity, and white matter and grey matter lies in between. T1 is optimal for demonstrating normal anatomy, and higher resolution is achieved in T1 sequences because of faster image acquisition. In T2 sequences, the CSF and the vitreous show high intensity. T2 has been found to be more sensitive to pathology as it maximizes differentiation in water content among tissues. Then we have FLAIR, that is fluid attenuated inversion recovery sequence, in which the CSF vitreous signal in the T2 is suppressed. So the CSF and vitreous give a hypointense signal in FLAIR sequence, making it particularly important for detecting periventricular lesions in demyelination, which may be missed in routine scans. Then we have the STIR star sequence, which is short tau inversion recovery, in which the fat is suppressed. As the signal from the fat is attenuated, it is useful to study orbits. In the orbits, we know there is orbital fat, and the signal from the orbital fat in a routine T1 sequence is very high. In the star sequence, we suppress the signal from the fat so that we have a better contrast for the remainder tissues in the orbit. Then we have something called CHESS, chemical shift selective fat suppression, also called FATSAT, which is useful for contrast imaging of orbit and pituitary gland. DWI is important. This is diffusion weighted imaging and gives hyper intense signal in very early ischemia, within minutes of the ischemia happening. So it serves as a time marker for the ischemic areas. DWI is often combined with ADC, called apparent diffusion coefficient. So the ADC technique helps to differentiate DWI signal detected in very early ischemic areas from other causes of hyperintense signals. And ADC shows the ischemic areas as hypointense signals. So this is a DWI image showing hyperintensity in a very early ischemic event. SWI, also called susceptibility weighted imaging, helps in detecting hemorrhage and calcification. And we have magnetization transfer imaging, particularly useful to detect early demyelination and tumors such as cerebral metastasis. Coming to magnetic resonance angiography and venography, it is meant for imaging large blood vessels to detect vascular pathology such as stenosis, aneurysms, plaques, dissections, malformations and fistulas. Since it is a flow-based imaging, that is, it is actually detecting the flowing blood in the blood vessels, the vessel diameters may appear smaller than computed tomography angiography or cerebral angiography. Thus, it may overestimate a stenosis. MRA can reliably detect aneurysms more than 5 mm in diameter and can be done with or without contrast. With contrast, the image acquisition time is short and the signal intensity is high. However, small vessels are poorly resolved on MRA, and MRV is useful in excluding venous thrombosis in patients with papilledema and can be done with or without contrast. So this is an MRV showing blockage of the transverse sinus on one side. Computed tomography or CT scan is well suited for bone calcification and acute hemorrhage. These are not well imaged in MRI. It is well suited for orbit as orbital fat is very radiolucent, providing good contrast to orbital structures. So orbital fat is very radiolucent and appears dark in the on the CT scan. Iodinated contrast materials provide for soft tissue imaging. These contrast materials may cause nephrotoxicity, so they are relatively contraindicated in compromised renal status, may cause allergic reactions. However, the incidence is low with low osmolar contrast media and should be used with caution in pediatric and pregnant patients. CT scan has a faster acquisition of image, so it becomes important in trauma and pediatric situations. Orbital varix changes during Valsalva, so it should be imaged very fast, and CT scan is important here also. Thin slice CT scans are required for the small structures in the orbit. It can be used in patients with metallic foreign bodies and implants, which are contraindications for MRI, and poor resolution of the orbital apex and posterior cranial fossa is a limitation of CT scan. CT scan uses ionizing radiation, and the dosage of the exposure to ionizing radiation is said to be higher than in conventional X-ray. So here we have a CT scan showing optic disc druseness and another showing hemorrhage in the brain. Computer tomographic angiography or venography uses iodinated contrast agent and exposure to ionizing radiation. CTA has a high sensitivity, 95%, for detecting aneurysms more than 3 mm and stenosis more than 70%. It has been seen that it can detect aneurysms as small as 1.7 mm. So there is a controversy that which one should be preferred, MRA or CTA, in such a setting. CTVs are image series at a later time after contrast injection used to diagnose venous sinus thrombosis or obstruction. Compared to magnetic resonance angiography and venography, CTA and V takes less time, shows the true lumen instead of the flow patterns. It is less sensitive to flow related artifacts. However, it is also less sensitive in picking up ischemic areas. Catheter angiography is the gold standard in intracerebral vascular imaging. It can identify stenosis, aneurysms, malformations, dissections and flow patterns. It is performed by inserting an intra-arterial catheter, usually in the femoral artery, and then placed in carotid artery in a retrograde manner, through which a radio-opaque iodinated contrast agent is injected. The usual imaging method is digital subtraction angiography, which eliminates artifacts from the skull bones and requires less contrast agent. So this is a digital subtraction angiography showing the middle cerebral artery territory. Catheter angiography has its morbidity from embolization, vasospasm, allergy and local reaction at injection site. Metabolic and functional imaging may detect abnormalities in patients with normal reports on standard MRI sequences. First, we have the positron emission tomography or PET. It uses tracers which have a ligand and a radioisotope. The ligand determines tissue distribution and the radioisotopes is used for imaging, combined with CT or MRI for improved anatomical localization of the radioisotopes. Most commonly, fluorodeoxyglucose or FDG is used. It follows the path of glucose utilization but gets trapped in the tissue as it is only partially metabolized, thus revealing metabolically active areas. It shows hypometabolism in ischemic areas and hypermetabolism in tumors. It is useful in evaluating cortical blindness and adnexal lymphoma and detecting systemic involvement in sarcoidosis and uveal melanoma. SPECT is similar, but instead of using radioisotope, it uses radio tracers which emit gamma rays. However, it has poorer specificity and resolution compared to PET. So this is a PET with CT with 18 FDG and 11C methionine showing a tumor. Magnetic resonance spectroscopy identifies biochemicals in the body without using any kind of injected molecules. The 1H sequence detects N-acetyl aspartate. Decrease in levels of N-acetyl aspartate suggests poor neuronal viability. 1H sequence can also detect lactate, which is marker of acute ischemia. 31P sequence measures cellular phospholipid levels, a marker of cellular energy use and membrane synthesis. MRS can predict which areas are at future risk of infarction, and it can help to differentiate tumors from other pathologies. Functional MRI is MRI imaging when the patient is doing a specific task. The task can be motor, can be sensory, can be cognitive. It measures differences in blood oxygenation level called BOLD fMRI of active and inactive areas. It measures the relative responses from diamagnetic oxyhemoglobin and paramagnetic deoxyhemoglobin. After neural activation, deoxyhemoglobin initially increases relative to oxyhemoglobin and subsequently decreases due to vasodilatation and increased blood flow. It is useful in preoperative and intraoperative localization of target tissues, for functional cortical mapping, and in evaluating cortical blindness. It does not require contrast. How to order and interpret a imaging study? Ordering is based on the following: the clinical presentation of the patient, the likely location of the pathology which is responsible for the clinical presentation, and the possible etiology of the pathology. So what are the errors in the process? We may have ordered an incorrect study. We may have omitted to order specific areas, contrast agents, slice thickness, and specialized sequences required for the expected pathology and its location. Inappropriate images taken can result in a false sense of security. We may reject a clinical diagnosis because of absence of abnormality in a properly ordered and a properly acquired imaging study. Or we may interpret an unrelated abnormality in the imaging study to be the cause of a clinical presentation. Thank you for listening.